I think quality of life, particularly in a non-trial population, in a real-world population of patients, is as important, if not more important, than survival. If survival is doubled or tripled, that may change the equation. But for most palliative cancer therapies, quality of life is very, very important to patients when you ask them. Quality of life to patients, however, is always a balance of toxicities and cancer symptoms. And they often tend to see the toxicities right away, and they don't often see in their mind what the symptoms of the cancer would be, down the road if they weren't on therapy. So having real quality of life data from a well-designed trial to show a patient is very helpful in convincing them to buy into a therapy. Yeah, the LUX-Lung 7 study, I think, confirmed the side effect profiles that we expected from our previous trial data. So it was nice to see that. It was also nice to see that the grade 3-4 diarrhea was quite minimal. It has been improving in every sequential generation of study with afatinib, from high numbers in the beginning to around 6% later in the Asian trials, and now to quite manageable small numbers. And I think that probably reflects increased experience both with the drug and increased experience for oncologists dealing with diarrhea generally. A lot of our drugs now cause diarrhea, and I think our teams, our nurses, our pharmacists are getting better at handling it. Diarrhea can be really difficult. Paronychia, I think we're learning how to deal with better. Right now we have a lot of anecdotal evidence. The rate of interstitial lung disease from gefitinib and the liver enzyme changes were pretty much in keeping with what we've seen before. Again, I think when you look at a clinical trial population, they tend to be more educated, perhaps more healthy, maybe somewhat younger than a real-world population. So if we were to extrapolate the conclusions from the study to a real-world population, maybe older patients, cultural, language barriers, I would tend to be a bit cautious, at least with the dosing, if we're not in a rush to get a rapid response. My partners and I often start at 30 milligrams of afatinib, for example, and work up to 40, even within the first 1 month, to make sure we are comfortable with the patient managing well. If they have more diarrhea, it becomes grade 2, 3 on 40. The patient will then remember that they did pretty well on the 30, and they'll feel comfortable going back to that. Whereas if they start off in, again, a real-world patient population, if they start off at 40 and have grade 3 diarrhea, it's very hard sometimes to convince patients to continue on therapy.